I work in a general hospital in China. I have do the clinical work and the research work. Today I will introduce a pilot RCT of ethosuximide in treatment-resistant depression, which is inspired by an antidepressant mechanism of ketamine. As we all know, the depressive disorder has caused the largest disease burden in the major 12 psychiatric disorders by about 37%. So developing a novel biological invention and improving the clinical management has been a pivotal challenge. The approval of esketamine is actually a milestone in the psychiatry field. As introduced by Hailan in the first day, a hallmark of depression is increased burst firing in the lateral habenular LHB. Her group also find that the LHB bursting depends on both the NMDA receptor and the T-type calcium channels. Therefore, ketamine can block the LHB burst to cause antidepressant effects. Their model also predicts that T-type voltage-sensitive calcium channels blocker may also cause rapid antidepressant effects. They went on to show that a T-type blocker, the ethosuximide, can cause rapid antidepressant effects in the forced swimming test and the serious prevalence test in mouse after chronic stress. Coincidentally, there are other two works also find ethosuximide can reserve depression-like phenotype, respectively in regular rats, epilepsy model commonly with depression, and in the chronic panic-induced depression-like mice. We know the ethosuximide is an anticonvulsant for epilepsy. Here we should ask two questions for the clinical translational work. The one is whether the ethosuximide has the faster antidepressant potential for depressive patients. How about the safety and the tolerance? Then our group collaborated with Hailan and designed a single center double blind RCT for verify the two questions. For the participants in the clinical trial, we provide the two-phase intervention. The first, the 2 week of ethosuximide, followed by the 4 week of the access plan. Our study's primary outcome is the mass scores changes at every 10 points from baseline to day 14, along with the plasma concentration of ethosuximide. Second outcome is the changes of QRDS and anxiety scores and the manic scores changes, regular laboratory tests and recorded side effects. In the trial, we aim to validate the efficacy and the safety of ethosuximide for TRD because of the potential similar antidepressant mechanism of ketamine. Here are the detailed inclusion criteria and exclusion criteria. This is the cost diagram of the trial. At the beginning, we plan to recruit 14 TRD patients. Here we should mention, because of the side effects, we terminated the trial earlier. Eventually, 16 the patients were randomized to two groups, 9 for ethosuximide and 7 for placebo. No differences in demographic profiles and clinical symptoms severity at baseline. The primary outcome about the mouse total score, we can see the trend of score changes was significantly different between two groups at day 14. So we can see ethosuximide group was superior to placebo group. The second outcome, we analyzed some the items of mouse, such as apparent sadness. We can see the differences in some time points, day 10 and day 14. Reported sadness, the differences we can see happened at day 10 and day 14. In attention, the differences between groups at day 10 and day 14. Especially the effect persistent to day 21. Inability to feel, also we can see the differences happen in the day 14. Perceptive thought, we also see the differences between two groups at day 14. Interestingly, the scores rebounded to higher than placebo at day 42. About the suicide thoughts, we can see in the intergroup analysis, the changes of the suicidal thoughts decreased significant compared to the baseline from day 3. Day 3, day 4, 6, 10, 14. In the clinical trial, we also analyzed the plasma concentration of etiology with the clinical effects. We know the animal data showed the concentration of ethosuximide was associated with the effect on the depression-like behavior in mouse. In the intergroup analysis, when in the day 14, the plasma concentration reached to more than 700, which is consistent with the level of the rat data. The differences the differences in mouse total score happened between the two groups. About the side effects, in the trial, the patients in ethosuximide group reported common side effects, which was shown in the previous studies. The primarily referred to the gastrointestinal tract, such as nausea, vomiting, and the central nervous system, such as dizziness, insomnia, and so on. Importantly, 3 patients switched to mania and hypomania. Because of the side effects, we terminated the trial in advance. Here we can learn more detail of the 3 patients who switched to mania and hypomania. One patient complained that many uncomfortable the symptoms after take the medication. One day, the patients seemed to derive some satisfaction from the negative sensation, perceiving them as a sign that the medication is actively targeting to brain leisure, leading to a transformation to their pain into something more profound and so far. And another the patient said, China is totally mine. Yeah, great-oriented delusion. If leaders were giving a dose of this medicine, the world would have been unified long ago. I should find a way to secretly buy some and keep my sprite higher. And just like taking drugs, I'm not fully aware, yet incredible, exhilaratingly. Sorry. So in terms of efficacy of ethosuximide, we find the significant reductions in mouse total scores and some items, such as apparent sadness, reported sadness, inattention, inability to feel, and pessimistic thoughts. Especially the pessimistic and suicidal thoughts failed among after gradually decreasing ethosuximide concentration. And in terms of faster antidepressant efficacy, the suicidal thoughts was potentially improved from the day 3. About the side effects of ethosuximide, in the human the studies commonly observed dose-dependent side effects of ethosuximide in patients are related to the gastrointestinal tract or the central nervous system. And cases of developing mania associated with ethosuximide for absence seizure has been reported in the past. So the limitation of the clinical trial included the relative small sample size and high drop rates. So in the future, we will replicate the results in a larger sample size multi-center RCT, and we will slow titration of the drug dosage and regulate the individual dosage. Ongoing work. We have begun a new multi-center randomized double-blind placebo-controlled clinical trial for validating the antidepressant effects of the drug. We will recruit the patients with major depressive disorder, not TRD. For increasing the therapeutic alliance, we will extend the titration time and increase the tolerance for the patients. Also, we will add a task FMI to investigate the neural mechanism and hope to confirm the biomarkers in the brain. So in conclusion, the pilot study preliminary demonstrated that the ethosuximide has the faster antidepressant effects for TRD by improving several symptoms. The plasma concentration was associated with clinical efficacy. The side effects related to gastrointestinal tract and the central nervous system commonly caused low tolerability and a high rate of dropout. So how to optimize the titration rate underlying the concentration and the tolerance for depressive the patients is a vital the challenge. So I should express the thanks for the Hailan and the Carlos, and the thanks for my group. Thank you.
Well, it was certainly doing something, wasn't it? So, anyone have any questions? Over there.
Thank you for the talk. So my question was, if you exclude the patients who developed mania, do you still see an antidepressant effect?
Yeah, when we recruited the patients, we used the MDQ and HCL 32 included the potential bipolar disorders patients. Yeah, and we also asked whether he have the episode of mania or hypomania.
I think what I mean to say is, within the trial, if you remove the data from those patients who developed mania during the trial, then what does the effect on the MADRS look like?
Yeah, it's a very important questions. You know, in the patients with the epilepsy, some anticonvulsant can cause the mania or hypomania. This is called forced normalization, which is associated with the remission of their symptoms, and the remission in the EEG, the EEG abnormality. So maybe the forced normalization is the mechanism of the anticonvulsants. Also, maybe such drugs is the antidepressants, the mechanism. So we discuss.
Okay.
Yeah, thank you. Thank you.
Can I just ask one last question? Your suicidality, it looked like after you stopped the drug, it went really high. And the suicide item, is that a withdrawal effect, or is it?
Yeah, it's very interesting. When we decreased the dosage of the suicidal ideation rebounded to the very high.
Yeah.
Yeah.
That's a bit worrying. Yeah. Thanks.
Thank you.
Thank you very much.